Many of you know Matt. He's a leader in the field of bariatric surgery. He practices at MGH, and he's had really a great impact not only on SAGES but SSAT as well. And he's a leader within NSQIP and an expert in these pathways. So we're excited to have him give a talk to a group that's very interested in bariatric surgery. Matt?
Tom, Bruce, thank you very much for the opportunity to speak. And very good. Thank you very much. And I'm very encouraged by the enthusiasm of everybody here today. I'll be speaking specifically about enhanced recovery in bariatric surgery. A lot of the points that we've talked about in general about ERAS we've touched on already by the speakers so far, so that has been excellent, so I can make up a little bit of time here from that standpoint. Disclosures, none related to this presentation. I am a PI on a grant to get patient-centered outcomes, and I went to a conference with Olympus, but they shouldn't reflect upon this here. Enhanced recovery in bariatric surgery. Why? And the first thing you'll find out when you're trying to do a quality improvement is you have to answer the why. If you can't answer the why, convince yourself of the why, but more importantly, convince other people of the why, you can't even get started here. So I'm going to focus a little bit upon the process of quality improvement as well as what we're looking at in bariatric surgery. But you have to be able to answer the why before you can get started. What's the why in bariatric surgery? What's the compelling evidence? Well, in colorectal surgery, we know that it decreases length of stay without increasing readmission rates. This has been shown over and over again. It's very convincing. A lot of colorectal surgeons had NG tubes in for a long time. They had ileus. They had extended lengths of stay. They made great ground movement with regards to that. Duration of postoperative ileus also has been dramatically reduced in ERAS. Why in bariatric surgery? Most of our patients go home the next day right now. It's hard to improve the length of stay. The limiting factor isn't necessarily that length of stay. I'm keeping them the next morning because I want to check their hematocrit more than anything else, not because they have an ileus or they haven't moved their bowels. Post-op ileus is really not a problem. Wound infection rates are quite low, and there have been a lot of correlations between ERAS pathways and colorectal surgery with regards to wound infection rates. But in bariatric surgery, our rates, thankfully, are quite low. So why? Actually, at the ACS, at the Clinical Congress a couple of years, there was a discussion about this, enhanced recovery in bariatric surgery. And the real question from very thoughtful people was, this is probably not where we should be focusing because we're doing it already pretty well. So what do we have to gain in bariatric surgery? Well, nausea and vomiting and inability to tolerate POs is an issue. Though many benefits might not be measurable with the metrics that we mentioned before, length of stay, postoperative ileus, it is the right thing to do. And now people understand that. Now since the doors have been broken down by colorectal, it's been implemented to other areas, that diffusion right now makes it easier to do in these other areas. But we do understand that minimizing the stress response, minimizing the insulin resistance in a patient population who has a very high level of insulin resistance, and opioid-sparing tactics are critical for the benefit of our patients, even though some of these might be hard to prove and get data on in the bariatric population. So the first challenges I've had with regards to this are why, and these answers actually have been quite good. Be able to convince people that this is the right thing to do, this is the right time to do it. So I encourage you to focus on the why. Bariatric surgery is different than colorectal surgery, and a lot of that's been developed is specific to colorectal surgery. It's foregut, it's not high gut. The reflux and aspiration risk is very high in this population. We're stapling across the stomach. And so what does that mean if you have a bunch of pills of acetaminophen or other pills in the stomach as you're about to staple across them? Dehydration is our major concern postoperatively. In fact, dehydration is why a lot of people are readmitted, not that they are necessarily overly hydrated. And the patient with a high proportion of diabetes, like I talked about, the issues around insulin resistance, about carbo loading right before they go into the operating room. So looking across at the ERAS pathways and randomized controlled trials that are out there with regards to literature, there's a lot, 17 in colorectal surgery, 5 in gastric cancer. There's only one randomized controlled trial in bariatric surgery, and that's on the sleeve gastrectomy. I want to give thanks to Stacy Brethauer. He's been leading this initiative through the MBSA-QIP. I'll be talking about more of that later on, but some of these are his slides, and he did share them with me. Literature search of looking at all the bariatric surgery outcomes that are out there. You can see these are mostly retrospective cohorts, commentaries, one randomized controlled trial, which I'll talk about briefly, systematic reviews, but the data with specific to bariatric surgery is not great, and there's a lot of opportunities out there. This is the randomized control trial for enhanced recovery versus standard care after laparoscopic sleeve gastrectomy. This is from New Zealand, 40 ERAS patients versus 30 standard care and 38 historical controls. This does highlight length of stay reduction. Traditionally, it had been 3. Standard of care had moved to 1. ERAS moved it to 2. ERAS had moved it to 1. But there were no difference in readmission rates, postoperative complications, postoperative fatigue, and they did demonstrate that cost was higher in the historical group versus ERAS. But with diffusion, with standard of care going already to 2 days, it wasn't difference between the standard of care and the ERAS group. So it does highlight some benefits here, obviously not a lot of power, but does point to the right direction that length of stay can be improved upon, depending upon where you start with your length of stay. In looking at this randomized control trial, they were already doing many of these things before the ERAS pathways, implementing preoperative education, the ward tour, the preoperative carbo loading. Those were the newer aspects of that, as well as the phone call 24 hours postoperatively. Now, as was presented just previously, there are now guidelines from the ERAS Society. The bariatric guidelines are listed here. I'm going to recommend, that we look at that one more time, and do highlight that this is the World Journal of Surgery from 2016. This is a good reference for people who want to look at it. The authors here, none of them are from the United States, but there's a lot of information that can be gathered from this. Paris, Argentina, New Zealand, UK heavily with regards to that, but there were a lot of questions we had with regards to implementation about, is this applicable to a US population? But I will refer to this. You heard about how these guidelines were developed and the methodology behind them, so I won't go over those. I do want to touch on some of the same points that were talked about before. The critical elements are listed with regards to preoperative information, prehabilitation. In this population, it's preoperative weight loss and specifically very low-calorie diets with regards to shrink the liver diets. Dexamethasone to help prevent postoperative nausea and vomiting, limiting preoperative fasting. But we have to think carefully about that. You know, these people, a lot of them are diabetics. A lot of them could have gastroparesis. Are we going to give them a food load right before we're going to staple across that stomach? Danger, Will Robinson. How about carbo loading in these patients who have a high level of diabetes as well? What will that do to their blood sugars? So all these things have to be thought about with regards to the specific patient population. Again, carbo loading, perioperative fluid management, postoperative nausea, vomiting, standardized anesthetic protocols. And really, the other thing to highlight here is with regards to the recommendations. You can see the evidence level and the recommendations. Well, a lot of these are quite low for bariatric surgery. However, even with low recommendations, sometimes there can be, with low evidence, there can be strong recommendations because the data is out there from other fields. It doesn't seem too far away from this. Even though it's not specific to bariatric surgery, we can borrow a lot. The diffusion from the other fields can be quite helpful. And so that's how these level of evidence work for these recommendations. Nasogastric tubes, again, the same theory from before. No tubes or drains unless it's needed. Laparoscopy, there's already a very high diffusion of laparoscopic surgery and bariatric surgery, so that's not as much of an issue. DVT prophylaxis, early ambulation. So now we have these guidelines, and what do you do about them? Well, you know, one of the daunting tasks here is you go to your hospital and say, I have these guidelines, I want to implement them, and it's like, ugh. How am I going to do this? You know, there are 4 surgeons and 2 of them don't want to do it. The anesthesiologist says it's a ton of work. Look at all these things we have to do. We have to get nursing on board. Really? You know, how am I going to do this? And the why, it's hard to answer that why question from the beginning because I can't say that we're going to reduce our length of stay from 1 day to a half. It's a challenge. But working collaboratively, I think this is where you can really get this economies of scale. You can get other expertise. You can get other enthusiasm. You can bully some people. You can get administrative support. There's a lot of benefits from working collaboratively. And we did this at our group, even though it was hard for us to get off the dime with regards to this at our hospital, at the Mass General Hospital. By working collaboratively with the other 5 hospitals in our network, it became a lot easier. We could share best practices. We got our current practices. What we did was we used this framework, the framework from the guidelines that I just showed there. Just put the spreadsheet out a little bit more and cataloged our current practices. What are the 5 different hospitals we're doing? And then the surgeons got together and say, okay, what can we agree? Are you doing that? I didn't know you were doing that. We never thought of that. wow, how are your patients doing? They're doing fine. Maybe I should try that. And all of a sudden, the bar really moved quickly over a couple of discussions from that standpoint. So catalog the best practices, have this framework from the guidelines, work together as a group. And then because of the 5 of us, the 5 hospitals, we had network support with regards to this. Project management, we're able to get it through in Epic when we couldn't get anything else through Epic. And so leveraging all these things from an economies of scale really makes a huge difference. A surgeon working group in order to develop best practices, anesthesia, obviously actively involved from that standpoint as well. And so I think the active quality improvement and how you do it is just as important, because if you just try to run up this hill by you alone at one institution, it can be much more challenging. In our colorectal group, where we were early adopters, we were thinking about doing colorectal or bariatric at the same time. No, there's a better why for colorectal. We did that first. We got to colorectal, and there were a few people who were never going to get on board. That's fine. We'll do a pilot and not include them. These things you really have to think about tactically and strategically in order to get that process. Colorectal started up as a pilot, diffused the other colorectal surgeons. They didn't have a choice. Diffused network-wide, just kind of organically from that standpoint. And I think that's how this can and should work. So here is our ERAMS pathway. We call it Enhanced Recovery After Metabolic and Bariatric Surgery. And we have all the different things. Here's our ERAS components just from that article that we talked about, what we have all agreed upon, and how we're going to measure compliance from that standpoint at our institutions. Now, we're working on doing this nationally right now. So through the MBSA QIP, the Metabolic and Bariatric Surgery Accreditation Quality Improvement Program, there's now this new initiative employing new enhanced recovery goals to bariatric surgery, the ENERGY Project, spearheaded again by Stacy Brethauer, the current president of the ASMBS. And we previously had a quality improvement to decrease readmissions. This is our second quality improvement project with regards to the MBSA QIP. Now, the MBSA QIP has robust data collection. It's 100% of cases, data is collected from that from audited, trained reviewers at every site. We have bariatric-specific data points, leaks, bleeds. It's risk-adjusted. Clinical effectiveness is collected, not just morbidity and mortality. We have long-term follow-up. We have a grant right now to develop the patient-reported outcomes. And it captures 95% of all bariatric surgeon operations in the U.S. It's about 800 centers in the U.S. So pretty robust because it's linked to accreditation. And that's what the MBSA QIP is all about. So initially around setting standards, verifying standards, having this robust data collection, but we've developed this quality improvement arm to bring this data to life. And that's what this ENERGY project is all about. So ENERGY, similar thing. Take the guidelines that were previously published by the ERAS Society, decide upon how we're going to implement them, and then target the right people in order to do this. And so these are all listed here. We look forward to getting them onto the SMART website here at SAGES in order to share these better practices. But the ENERGY program right now is including those same variables, pre-rehab, pre-op visits, what to do at each phases of care and who's responsible for them. Includes a quality of recovery scale, the QOR 15 scale, in order to look at the quality of recovery. Our patient-reported outcomes are looking at longer-term preoperatively and 1 year later, but measuring recovery will be one way to do that. Since we have the data collection, we can look at unintended consequences, we can make it risk-adjusted and procedure-specific. We have all that data linked to already the data collection, but now adding these process measures and measuring compliance with regards to them will be what we will do. But again, the process of doing this can be quite challenging, not only to agree upon what needs to be done, and again, the list is pretty daunting, not only to develop, but to do. But when you're doing it collaboratively, the thought is that we will be able to do this better, and that there will be an economies of scale. Again, all these details are too much to go over right now. The concepts are similar, and they will be available hopefully in the SMART website. And for this project, we decided to look at the high outliers. So we already know, from the 800 centers that we have, we can look at the centers who have an issue with regards to length of stay, with regards to readmissions from postoperative nausea and vomiting. And we can see how they did in 1 year and then the second year and target the hospitals who may benefit most from this. Now, basically, I think everybody, these hospitals, could benefit from this. But if we target the hospitals that need it most, perhaps we can demonstrate the greatest change. So the sites have been selected. This is the rollout with regards to this. It takes a little while to do these things, but the sites have been selected, agreements to centers, a rollout at Obesity Week with regards to this. Now, a key thing with regards to this is having these mentors. So a mentor in order to talk to each one of the sites about how to overcome the burdens of quality improvement. because it's not just having a pathway, it's really the art of getting it implemented at your institution. Now, having a national accreditation body puts some weight behind it. It has some expertise. Well, the experts agreed upon this, so it has face validity right up front. So it tries to get over that, but without kind of the mentorship and the frequent touch points in order to get people through there, we think it would be much more challenging. So this has been built into the program as well. So ongoing mentor teleconferences and webinars to check in as it's developing, a run-up period of 6 months because these things don't happen overnight. Even when you say you're going to do it and you have the checklist, you have to get anesthesia and everybody on board locally and then to help roll that out. So this is what's going on in bariatric surgery. This is how we're trying to implement it not only locally at collaborative levels, but nationally in a national collaborative from that standpoint. And stay tuned. It'll be interesting to see what we find out from this. Thank you for the opportunity to speak today.
Do you have time for questions? Does anybody have any questions for Matt?
Lana Nelson from Norman, Oklahoma. 2 questions. We were a program that wasn't selected to participate in the Smart Recovery, so when will that really be available to us in terms of protocol? Because, you know, sometimes it's difficult to reinvent the wheel when you all are already doing it. And then the other question is about preoperative carbohydrate loading. Does it really matter what the source of carbohydrates are? Some would suggest that you need to use one of the commercially available products like the ClearFast, and yet you also allow either Gatorade or apple juice, so how important is that?
Yeah, I think we don't know. One of the challenges from this, when you have this kind of shotgun approach, it's really hard to isolate any one of those single factors. There's practical realities of quality improvement. Some of the commercially available products, which we use in our colorectal, are extremely expensive. We had to get a grant from the hospital in order to provide that to the patients to get patient compliance. That is not something generalizable. So yes, in this pathway, it does include apple juice. It does include Gatorade. It does include opportunities for this as well as some of the other commercially available product. But I don't think we'll know at the end of these which product is better or how it works from that standpoint. With regards to dissemination of this, I think they were working through some of the fine points before they disseminate it widely in order to get some of the kinks out. But when those kinks are out, we look forward to disseminating it more widely.
Thank you.
The goal is not just to have it for those sites, it's to make it available for everyone.
So that gives me thanks, Matt, very much. That gives me the opportunity to put in a plug for this afternoon session. We're going to have a real nuts and bolts session from 1 to 5 today that's in the program. And one of the topics we're going to talk about is the practicality of the carbo load. And really, what are you trying to get out of it? Are you prehabilitating a malnourished patient? Or are you just trying to facilitate the glucose control during the perioperative period? So hopefully we're going to get into the nuances of some of that too this afternoon.